Good evening, everyone. We welcome you all to ORTHO-TV in association with Pediatric Orthopaedic Society of India. To introduce today's topic and the speaker, I hand over to Dr. Dhiren Ganjwala, President of the POSI.
Welcome to the 45th webinar of Pediatric Orthopaedic Society of India. This is the second in the series of surgical technique, and today we are really fortunate to have, we will be able to learn this technique from the masters, and the topic is the Physeal Bar Excision. We see Physeal bar formation because of the trauma, because of the infection, or sometimes because of the surgery. And we really need to learn this technique because it's not that easy. And I'm sure that today's session is going to help us to learn this technique in a better way. We are really fortunate to have two experts from the Texas Scottish Rite Hospital. And the faculty are Dr. Karl Rathjen and Dr. David Podeszwa. I will give a brief introduction about them. The Karl is like the Assistant Chief of Staff at Texas Scottish Rite Hospital for Children. He's a professor at University of Texas Southwestern. He was a past president of Limb Lengthening and Reconstructive Surgery Association. And he was also a past president of American Orthopaedic Association. David also is in the same team. At present, he is a director of Limb Lengthening and Reconstructive Surgery. He is also a professor at University of Texas. In addition to that, he has a leadership role at American Academy of Orthopaedic Society. And he is a deputy editor of Journal of American Academy of Orthopaedic Surgeon, particularly looking after the deformity corrections and the pediatric part. In addition to orthopedics, he enjoys skiing, flying, and rowing. And recently, just now, he said that he is also appearing for the pilot exam in the recent future. Our own Mandar Agashe will be moderating the session. He practices as pediatric orthopedic surgeon at Mumbai. He is a co-director of hip preservation surgery at SRCC Hospital in Mumbai. In addition to that, he is an editor of Indian Journal of Orthopaedics, and he has co-authored a book on pediatric orthopedic trauma, which published this year, and that's about the protocol and technique. So Mandar is going to moderate this session. About the format, after a short introduction, I will hand over to Karl, and he will show us a few cases. And after that, we will have a presentation by David about showing the surgical technique in depth. After that, we will be able to take few questions because I am sure that we will have a lot of questions on this technique. And if you have any question, you can send your questions to Mandar on WhatsApp or on text message. The number is 91, that's a code for India, 9920023246. I repeat, the code for India +91, and the number is 9920023246. Before I hand over to Karl, just a brief introduction about upcoming webinar. We are really fortunate to announce that on the 23rd of October, Saturday, we are starting a new series. That's a POSI POSNA webinar series. And we are going to have this time the lectures and the case discussion on fracture shaft femur and fracture neck femur. So please book these dates in your calendar. And at the end of the month, on the 29th October, Friday, we have a leadership awareness series in which we have fortunate to have Stuart Winstein with us, James Wright from Toronto, and Scott Cousin. They are going to tell us about the leadership they are doing in their practice. So with that, I hand over to Mandar first and then to Karl for the talk. Over to you, Mandar. Thank you.
Thank you very much, sir. So, as sir said, Physeal Bar Excision is one of the most difficult surgeries and sometimes quite unpredictable surgeries for a pediatric orthopedic surgeon. And we have two stalwarts who are going to share their knowledge about this surgery to us. So, without further ado, I would like to invite Dr. Karl to start off with his cases, and then we'll have the next session with Dr. David. Over to you, sir.
Thank you, Mandar. Is my screen coming through?
Yes, sir.
Yes.
Excellent. Well, thank you all for having us. And I applaud your use of technology, and hopefully we can learn from one another. We certainly, I think, have already learned the benefits of you doing this remotely and recording it and making it available to your membership, which is really phenomenal. I think there's no question that in the last year and a half around the world, we've all been stressed, we've all learned a lot, but there will be some really valuable things that we take away from it. And this ability to meet remotely and internationally like this is unquestionably one of them. So thank you very, very much for the opportunity. We have, I think, no relevant disclosures to any of this presentation this morning. Here's an example of an 11-year-old boy with the Salter-Harris-2 distal femur fracture. Was treated with screw fixation of the Thurston-Holland fragment, and then rotational control provided by a smooth pin, which was removed in about 3 or 4 weeks, and he went on to heal uneventfully. He showed up, and this is on your left is his immediate cast removal X-ray, and he shows up about 9 months later, and you can see even better than a Harris growth arrest line that he has asymmetrical growth, and there's some concern about perhaps some irregularity or closing down of this physis. That led to investigation with a CT scan, which demonstrated really a physeal closure on the lateral side that is pretty large. And he was taken to the operating theater, and he had attempted resection of this physis, and you can see just a little surgical trick maybe is taking a dye and kind of putting some dye in the bed of the resection where you've tried to resect the physis, just to ensure that you have that completely resected. And one of the things, hopefully, that after spending some time in this webinar that you'll remember is it's really, I think, important and very helpful to put in these radiographic markers that mark both sides of in the metaphysis and the epiphysis, so that you're marking on the hemiepiphyseal side of where you did the resection to kind of watch for future growth and get some idea of how the physis is performing after the resection. So this is where we left the operating room, and he comes back again now another 6 months later. Clinically, it looks like his valgus has gotten worse. You pull up the X-ray from the operating room, and you can make measurements across this, and you can study this, and you can see that by all means, there's been no change to these radiographic markers put in. So unfortunately, you can deem this attempted physeal resection as a failure, and quickly go on to, at the very least, complete the epiphyseodesis so the angular deformity does not get worse, does not worsen, and then deal with the angular deformity and shortening in the future. And so this patient eventually went on to external fixator and angular correction lengthening and a contralateral epiphyseodesis to manage his growth disturbance. So I think one of the take-home messages, rather than just show home runs, is that, and not to steal all of David's thunder, but we have found that this procedure gives you some growth only about half the time. And so you certainly need to counsel the families. You don't want them lost to follow-up after you do this. The patients have to understand that if this has a chance to work, but it has an equal chance not to, and close follow-up and having plan B and C and maybe sometimes even D in your mind are an important part of the surgical planning. Here's another example. This is a 7-year-old girl with infantile Blount's disease. And you can see my preferred technique. Last time I showed you a CT scan to identify the bar. I think it depends, in my opinion, it depends a little bit on the radiologist that you work with. Some of our radiologists are really fond of using the MRI scan. They can do a cartilage specific sequence, and then they can even take that and map it on a 3D workstation. And so here's a 3-dimensional map of the physis in cross section, and they have shown me the area where the physeal bar is, and they can give you a example of this, or an estimate of the size of the bar, all done by the radiologist on their mapping section. So our plan was to resect this bar and to do an acute osteotomy in the 7-year-old with pin fixation and casting, so pins and plaster, to realign the normal mechanical axis. That's a point I think that's really important. Probably 30 to 50% of our physeal bar resections also have a concomitant osteotomy. And the concept of the Hutter-Volkmann principle, which is to not, you want the stress across the physis to be evenly distributed, not overloaded on the sick side of the physis. So here are the intraoperative photos. We didn't have dye here, but we used fluoroscopy to demonstrate in 2 planes the extent of our resection of the physis. And then here we are with this is a modified RAB kind of dome osteotomy. This line right here is the Bovie cord, which is placed from the center of the hip to the center of the ankle. So it's a mechanical axis. And we're going to be deliberately and trying to overcorrect this into valgus, which will help unload this medial physis and improve the Hutter-Volkmann principles, and hopefully help restore that physis, give it a chance to grow. And then you can see again the critical placement of these radiolucent markers to give us some idea of whether or not we've been successful with the physeal resection. Here's the patient after the pins and plaster have been removed, about 2 months post-op at our first standing x-ray. We're very happy with the valgus alignment, and we're hopeful. We're going to watch closely to see what happens to our physeal resection. And this time, so here she is a presentation. Here she is at that, 2 months out of surgery, first standing radiograph. And here she is 4 years later at 11 years of age. And you can see she's maintained excellent growth. We've had tremendous growth from the physis, so it's been very successful. We're very happy. One thing David will talk a little bit about is even when you have, this is a home run success. This physis is going to close before this one. And so being aware of that and being prepared to close this physis with a contralateral epiphysiodesis to prevent any limb length inequality, and if necessary, to equal out the limb lengths with the distal femoral epiphysis. Here, I think we were fortunate we didn't have any limb length inequality. So as this physis was slowing down, we went ahead and did the fibula and tibia on this side. And so she, with really just 2 operations, we were able to manage Langenskold 6, very severe infantile Blount's deformity in a 7-year-old. So this is unpublished data. John Birch and I did a review probably 12 years ago or longer at our bar resections, and then John subsequently revisited that and published it. And David is going to share that data with you. But what we found, this is the area of the bar. So classically, that 50%, we found that our bars were by and large much smaller than that, and that the smaller the bar, the 0 to 10% bars, did significantly better than those at 10 to 20% or greater than 20%. So a small bar is going to be more likely to have some resumption of growth. And then younger patients, not surprisingly, that the velocity of growth that you have to overcome it. So about nearly 90% of the patients under 10, this is the typo here. It's 87% under 10, and only about half the patients over 10 had resumption of some growth. So I will give you 2 more kind of case examples. Here is a peripheral, very small bar. You can see the Harris growth arrest line is coming down to the physis, is asymmetrical. The bars resected, again, the radiolucent markers are placed. And now you can see this is with growth that has been symmetrical. And so this was identified and addressed and treated very early before there was angular deformity, and a nice result. Pretty rare to see post-traumatic growth disturbance in the distal radius. Very most common, probably physeal fracture that we see. Very unusual to see have a growth disturbance. There's a central bar that was resected. Again, the markers were placed. You can see the ulnar positive variance is already present with shortening there, but it hasn't worsened. And you've had some resumption of growth. So there's no question that this is a really valuable technique and something that you have to have in your armamentarium. It's not terribly common. I don't think any of us do this, more than a few times a year. And so it's always nice to run it by your more experienced colleagues, get their tips and their trips. And David's going to give you a lot of the intraoperative tricks on how to make that smoother. My plug would be for making sure you have the metallic markers. I think that this is a great operation in younger patients with smaller bars. And I'll leave it at that and kick it over to David. Thank you very much.
Thank you, Karl. And again, I would like to thank Mandar and Dhiren for the opportunity to be here. It is an honor to be a part of this webinar, and I hope that this is something that in the future, both from an organizational standpoint between POSNA and POSI and institutionally with POSI, that we can continue this relationship. So as Karl said, I'm going to now talk a little bit more. Let me get the screen up. There we go. Where, when, and how to resect a Physeal bar. So we'll talk a little bit more in depth about the technique. I'm not going to go into sort of what a bar is and some of the etiology. I think we all understand that. But I am going to talk a little bit about the background. Then I'm going to talk about the technique and a little bit about the results that are in the literature and within our own institution. So the first report in English was actually Langenskold in 1967, and he again published it in 1975. The concept was to evacuate the bar and to identify, in this case, the peripheral bar, and leaving the healthy physis untouched. So if we take away that bar and again put in our markers, we're going to fill the cavity with some material, and typically that's going to be fat. Whether the patient needs an osteotomy depends on the lower extremity alignment. And again, whether you use or not use markers, we feel very strongly that markers are very, very helpful in determining growth. The surgical treatment of partial closure of the growth plate, again, Langenskold in 1981 published his first sort of results and demonstrated that 86% of the patients had restoration of growth and correction of deformity. However,
Teams, I think this is my microphone and this is
Karl, mute, please. So Langenskold first reported this 86% of restoration of growth and correction of deformity, but did not get into any other specific detail as far as the results. Ham Peterson from the Mayo Clinic in 1984 published on 71 patients, and 70 of them experienced some growth with only one failure, with an average growth 84% of the contralateral limb, which is significant and a really, really good outcome, and has been very hard to reproduce that sort of outcome. So the surgical indications for bar resection historically has said anything less than 50%, but 25% in our world is probably better. And then we also look at remaining growth, and historically it says at least 2 years of growth remaining. And I think that's very fair. However, if you're 2 years and it's going to be pure leg length that you're worried about, then I think completing the epiphysiodesis and a contralateral epiphysiodesis is probably reasonable if you're calculating the growth remaining and calculating, the leg length you may be giving up, I think is very reasonable. So I think that 2 years comes into play for growth. I'm going to show you a case later on with 2 years and sometimes a little bit less of growth remaining for a deformity. And we see some deformity correction after bar resection. So that's a little bit of a gray area, but I definitely wouldn't do it less than 2 years of growth. There are other options that would achieve a really good outcome. And this is just another way of picturing the surface area of the proximal tibia, and 25% of that surface area is a very large area. So to think that up to 50% could be resected and work well, I think is really a leap of faith. So that's why we kind of look at 25% or less. Classifying our Physeal bars peripheral, central, and linear, are very, sort of classic, but this helps us to identify what our approach is going to be. And we're going to take the peripheral and central, and central, and we'll look at a linear as well, and the techniques that we use for each of these bars. So when we look at the surgical technique for a peripheral bar, again, we're identifying the bar and we want to resect that area back to good physis. The preferred option is to identify the physis at the margin of the bar and work toward the opposite margin. So again, we're just going to find healthy physis and then resect that bar until we see good physis. So this is an example of a 7+ 5-year-old male who had also had a Salter-Harris 2 distal femur fracture, underwent closed reduction and cannulated screw fixation, and 18 months later was demonstrating that there was no growth from the distal femur with an early flexion deformity, right? So suggesting a posterior physeal bar. When we look at the CT scan, as we scroll through the sagittal cuts, you'll see here the posterior, bar tether of the physis. So this patient underwent a popliteal dissection, a direct bar exposure, and resection. So we put in a guide wire directly into the bar, and this was removed from this area, and then our marker wires in the epiphysis and the metaphysis placed after removal of the peripheral bar to monitor our growth. So at 3 months, 14 months, and 29 months, you can see growth and actually a slight improvement in the flexion deformity. So that has, it was an excellent outcome. And really, as you'll see in our institutional data, we really describe success as anything over 6 months of growth we consider to be successful. Now, may not be awesome, but any growth is better than no growth. So this was very successful for almost 2 years. When we look at the surgical technique for a central bar, this is where we're going to make a metaphyseal window, or some will make a metaphyseal osteotomy so as to use the osteotomy cut as your window. But for most of the cases, and certainly in my experience, I've been able to make a window or literally a trap door to allow exposure for that area. So the use of computer-assisted guidance, CT scan, and other computer-assisted guidance was described from Korea in this report in 2010 from the British Journal. But it was this report in 2006 that was really the first report of using arthroscopy to help guide your central bar resection. And it's arthroscopy really to look in the metaphysis and look at the bar itself to see how much you have resected of the bar and whether you have a complete visualization of the physis. And we'll show a couple examples of that moving forward. So this is a case again of almost a 7.5-year-old male who also had a distal femoral physeal fracture that was treated with closed reduction and smooth pins. And it was followed for evidence of growth arrest. And you can see the growth arrest here at the area where the pins cross the physis. And you're going to see that again here on the CT scan. Now, what you'll notice is the cases I'm showing have CT scans. And you'll see right where the pins cross, you'll see the physeal bar on the sagittal, or excuse me, on the coronal view. Now on the sagittal view, you'll see the same thing. You'll see this more of the central bar. Oh, I'm sorry. Got a little aggressive there, but there is the central bar there. So you'll notice again, the CT scans in these cases. Karl had mentioned that he likes to use the MRI and be able to map it with the MRI. I prefer to use the CT scan because intraoperatively we have a CT scanner, and I use that CT scanner intraoperatively to, particularly for the central bars, to identify the location of the bar and identify the location of my pin placement, because this first pin placement that you see here is really the key to the procedure, because it's over that pin that I'm going to put my first reamer and really then work on reaming and opening up that bar so that I can see a complete circle of distal femoral physis. So we've created a metaphyseal window. We've put our guide wire in. The location is confirmed under CT scan or a 3D fluoroscopy. A second guide wire, in this case, because it was a oblong shape of the bar, we put in 2 guide wires to allow for reaming. Gradulated cannulated drills to remove the bar, depending on how big the bar is. Our biggest one goes up to about 10 millimeters. So sometimes we do need to place a second pin, or we'll follow that with a burr. And then we're going to look inside with an arthroscope. And it's typically done dry. I have done it where we have been able to keep saline in the wound to make it a little bit clearer for the camera, but oftentimes it's just going to be a dry. But if you use a 70 millimeter scope and you put it in, you'll be able to easily see the circumferential physis. And this is what you need to see. If you don't see circumferential physis when you are done, then you're not done. And you need to identify the circumferential physis. In areas where you don't see it, we will then go back with a burr, usually a 4 millimeter burr, and just carefully take away the bone in the areas that we can't see the physis. And when using that burr, it's important to be perpendicular to the physis instead of being parallel with the physis and just grinding out physis. If you're perpendicular to the physis, it allows a little bit more control and a little bit less injury to the physis. So we then inserted our epiphyseal and metaphyseal markers. We use fat as an interposition and stuff the whole cavity with fat, and then replace the window, or if you just drilled out the lateral cortex or the medial cortex, which direction you're working from is fine. You're just going to, and then have protected weight bearing following that. So this patient, 9 months post-op, 17 months post-op, and 23 months post-op show a continued growth of the distal femur after resection of that bar, and which is really nice growth at that point. This is the picture at 23 months, but then at the 23-month mark, the patient got lost. And again, it goes back to what Karl had said too, the importance of following these patients, because growth does not continue normally. So this is now at 69 months post-op, and you can see the patient has developed a leg length difference. Now, because the left distal femur stopped growing prematurely, it was very successful in obtaining growth, but that growth is almost never sustained until the end of maturity, and this patient was left with a leg length difference. And now we're getting to the point where a contralateral epiphyseodesis was probably not going to make up that difference completely. And there was definitely an opportunity to identify that left side slowing down and performing epiphyseodesis so we don't develop this leg length difference. So we see that premature cessation of growth after initial success is by far the most common outcome. Just one observation, a little restoration of growth combined with modulation can be a good thing. And this is an example of a 15-year-old male who had a transmetaphyseal drilling of multiple OCD lesions in the knee. And he developed a progressive right leg valgus deformity and was continuing to have knee symptoms. And you can see that just based on the x-ray, without even doing a bone age, that there is not a lot of growth left. And at 15, you wouldn't expect that. The CT showed this anterolateral peripheral bar, even though the bone age suggests he did have 2.5 years of growth remaining, and the family wanted to do whatever they could to avoid a high tibial osteotomy. So this is a 3D reconstruction demonstrating, again, the bar. And after the bar resection, you can see this peripheral bar resection here, sort of anterior and anterolaterally, again with pins placed in the metaphysis and the epiphysis. A growth modulation plate was placed to correct the valgus. So there is opportunity to regain growth and use that growth for modulation to correct angular deformity. In this case, this worked out very well. He corrected, stopped growing, and fortunately, that was all he needed. So we were very fortunate in this case. Final recommendation really is to keep it simple and to not make the surgical approach or the resection any more difficult just for the sake of a few millimeters of the healthy physis. This is an example of a 5-year-old girl who underwent open reduction and fixation of her Salter-Harris 4 medial malleolus fracture. As you can imagine, this developed a growth arrest, as many of them do. You can see this arrest anteriorly. CT scan, again, confirming the bar here. And this is just a short video demonstrating the technique for this type of bar, whether it be sort of peripheral or really more of a, we frequently see these linear bars in the distal tibia. So what we're looking at here again is the AP radiograph, and you can see the Harris part growth arrest line going down into that bar. This is demonstrating normal physis then up to the bar. Normally we don't expose it completely, but for the sake of this case, we did expose it so we could visualize where we were putting this pin. We didn't use a CT scan in this case because we were visualizing it directly. We placed that pin from front to back directly through the bar, and then use this reamer to ream the bar. And again, here's an example of putting that arthroscope into the wound, into the epiphysis and physis itself, looking at the physis. And again, you should be able to see that white line of physis all the way around to know that you've completely resected it. Place the metaphyseal and epiphyseal markers, taking fat. Now, where you take the fat from is sort of dealer's choice, from the buttocks or something locally works very well in most cases, and stuffing the hole with the fat. You can see the markers. So when we're going to talk just for a moment on the results of bar resection and the results of mere mortals like ourselves, unlike Langenskold and Peterson's really successful early work. There has been other work. Dr. Staley in 1990 published results that many of us see. 22 patients, half were good. Several not nearly as good, but again, small bars were more likely to be successful. Again, a report out of Australia from Bruce Foster in CORE in 2002, again, about half the patients doing well, but many had retethering during growth, and that the outcomes are unpredictable. Again, not uncommon experience. And then Ham Peterson, again, from the Mayo Clinic, looked at 51 patients over 28 years, and reported on the idea that there's an initial burst of growth that can be greater than the contralateral normal physis. And we do see oftentimes a burst of growth, which is quite helpful. But what you'll see in his data, and it's similar to ours, that 30%, almost 30% of the patients had no concurrent or subsequent surgery. So the flip side of that is 70% are going to have another operation. And that is definitely what we see. Even in those that have continued growth, 70% at least are going to need another surgery. And that is really important to, again, talk with your families about, to know that, what is the definition of success and what should we expect in the long term. So if we look at our institutional data, and I have to thank John Birch and Satish Manchanda, who were really key in getting this data together. We looked at 92 lower extremity physeal bars and followed for at least 2 years or until their next surgery. And you can see that the majority of them were in the, half of them were in the proximal tibia. It was pretty evenly split between males and females. In Blount's disease, as you can imagine, in the proximal tibia was the vast majority of those. But trauma in Blount's was really the main etiologies. Again, looking at those who grew more than 6 months, what we found overall was that gender, etiology, bar size, even though other studies have suggested that a small bar size makes a difference, in this group of patients, bar size and location were not statistically significant factors in predicting success or failures. When we look at these patients that it really about 50% or 55%. So we basically just in our mind think this is a 50-50 procedure. That 50% grew at least 6 months. Now, granted, 40% of them grew, more than 2 years, but really it's a coin flip on whether this is going to work, even in the best of hands and using the best of techniques. Complications, really just over 6% developed complications, deep infection, compartment syndrome, wound dehiscence, having to revise the marker. And 100% of patients with no growth had subsequent surgery, as you can imagine, either for deformity correction or for addressing the limb length, whether it be with epiphysedesis lengthening or some combination of osteotomy with those procedures. And again, in our population, 75% of the patients with growth had a subsequent surgery. Again, similar to Ham Peterson's long-term data that suggested 70% in their group. So in summary, how much might the patient gain from a 50-50 operation? That's a question that really has to be taken into context with the patient and family. Where is it? What caused it? How big is it? And how much growth or deformity benefit will you achieve from this procedure? Which physis, skeletal age, 2 years of growth remaining. I think that's really key. I don't think that's universal, but it's really, really key. If you've got less than 2 years of growth, then I think that it's a no-brainer that it should not be done. Other operations, are they a better fit? Completion of the epiphysedesis, contralateral epiphysedesis, osteotomy with or without lengthening are options, and oftentimes very good options depending on the patient, the family, and all of the things that we just discussed. So again, keeping it simple, 3D fluoroscopy or CT intraoperatively is very, very helpful if you have access to it, particularly for the central bars. Core it out, check it out. So if you can use arthroscopy, if you can get a camera in there to visualize the physis, then you're going to know you've resected the complete bar. Stuffing it with fat, using markers, follow them regularly because again, successes will have a late deceleration of growth. Markers are very important to document exactly how much growth you're restoring and can help identify cessation of growth before you start to see leg length difference and deformity developing. So I would like to take a moment to, one, thank you again for allowing me to be here and present this talk, but I would also like to put in a plug for the third Controversies in Pediatric Limb Reconstruction, which we will be hosting here at Scottish Rite Hospital in February of 2022. We have a great faculty. You can see the conference agenda, including lengthening of pathologic bone, stimulation of bone healing, challenges in the treatment of joint deformity, and what's new in limb lengthening. This will be live streamed in addition to being hosted in person, but we'll be live streaming it for the first time this year, given the troubles with travel, particularly international travel. So those who are interested, will be happy to forward this information to Darren so that this can be sent out to the greater organization, and look forward to hopefully many people joining us for that meeting. So again, I'm happy to answer questions now, but if you have questions or anything moving forward, don't hesitate to reach out to myself or to Karl as well. And thank you, and really appreciate the opportunity to be here.
Thank you very much, Dr. David, for this excellent talk. It was really a great collection of cases between you and Dr. Karl, and it really opened our minds about this procedure, which even as you said, in the best of hands, has a 50% chance of success. So we do have a few questions. The first is, whenever we do it, we always have a difficulty in putting the graft and keeping it in place, particularly with respect to how to pack it in and when do you release the tourniquet. Because what happens is that after tourniquet release, it just, there's so much of bleeding, it just, it's difficult to keep that graft in place after you have put it. So are there any tips and tricks about how much of graft to be placed and how do you see to it that it is secured inside?
Yeah, I completely understand what you're saying. Sometimes packing it with graft, you feel like is a little bit of leap of faith as well that it's really doing anything. Now, that being said, when I'm doing a distal femur, using a trap door, I think is helpful because you can then put that trap door back and try to cover it with periosteum to hold that in. And the key there is to pack not only the epiphysis and physis with fat, but the whole canal with the whole metaphysis up to the cortex with fat to help keep that down. And then if you have that trapdoor over it, and even if you don't, if you can, it's not easy under most circumstances, but getting the periosteum back over that area. So I think packing the whole area with fat is important, because if you just pack it at the physis, then yes, it's probably going to move. And we don't, to be honest, I don't think we don't really know that makes a huge difference, right? There were many people for a long time, particularly, and even at this institution, would pack it with bone cement. But I think we've seen issues with that, not necessarily in affecting the success or failure, but if you have to go back for a secondary procedure, having that in place makes it really difficult to work around. So anything you can do to fill that whole area with fat, I think, is probably the best way to do it, and then get something to cover it.
Yeah, I think Dr. Sandeep had a question.
Yeah, I just wanted to ask David or Karl, either of you. There have been some studies which are being published of use of stem cell. In fact, the patient I was talking to you informally before we started the webinar, I had a child who said that his cord blood has been stored. And can you use that to regrow the cartilage after you resect the bar? So what's your experience with either cord blood which has been stored, or stem cells, or cartilage transplant, which people are experimenting with?
I don't have any experience with the use of stem cells for this procedure. The replacement of cartilage doesn't make sense, and only to me, because you're replacing a physis, a growing structure, and I don't think we have that yet. And I'm not sure. I'm not familiar with any data out there that suggests that putting in stem cells is going to regenerate physis and prevent the regrowth of a bar. Is that technology down the road? It might be, but I don't think we're there yet, and we certainly don't have any experience with that.
Yeah. So corollary to the first discussion as well as this question. So do you have any experience with any other material to be used as interposition? Something like cranioplast?
Cranioplast was used at this institution for many years. And again, particularly in Blount's population. It was used for many years in the Blount's population. And it worked well as a substitute to keep bar from reforming. Again, that goes back to the idea that when that cranioplast is there, and it made secondary procedures very difficult. And then we had trouble getting cranioplast for a long time. There were issues with supply, and I think it fell out of favor a little bit just because we didn't have it. But we have seen issues with secondary operations with the cranioplast in place. That's the downside to it. If you had it and used it, I don't think I wouldn't be critical at all of its use.
All right. So one more question is the radiographic markers which you use. Do you use SS or titanium? Because in the future you may have to do an MRI. So does it make a difference, or it's all the same?
So I think that's a great point. We've been using markers for the lack of any other material. Now, that being said, there was a study out of New York using tantalum beads to use that. And we are now in the process, it's hung up in purchase and legal, logistical issues at our own institution. But we want to move to using these tantalum beads so that they're a little bit easier to place, they're smaller, and they can still be used. And then there's less scatter or problems using subsequent CT scan or MRI. So yes, I think the wires you could argue, are a very crude way of doing it, and that we're going to transition away from those to these tantalum beads.
I think Dr. Patwardhan had another question.
Yeah, so for the uninitiated, if you can just tell us what is the end point of the resection of the bar? When should you stop? Because I saw that all your resections are pretty wide. So how do you say that, okay, this is enough? And
So
instead of underdoing it, would you rather overdo it?
yes. So yes. Well, I had that slide about, don't, being, yes, there's a fine line between too much and not enough. But if you have good visualization with a camera, then you know when to stop. The holes are big because the bars are big. We base the reaming on the size of the bar based on the CT scan preoperatively. And then when you put the camera in, if we can't see, for example, in the distal femur, if you can't see that circle of physis, then you're not done. When you see that full circle of physis, then you stop. And yes, there may be areas where you take a little bit more normal physis out with the reaming just to make sure you do it, but it's better than leaving bar there that's then gonna, cause an early failure or cause failure from the start. So really we make a big effort to be able to look inside and see it, and then we know we're done.
All right. Also, one more question. Sometimes we get reports from MRI that we have something called as a fibrous bar, especially post-infection. So do you have experience? Because sometimes we have seen that these bars break and growth resumes.
Yes, we absolutely have seen that. We have seen the fibrous bars, or what we assume is a fibrous bar because there's no bony bar, but there's clearly with growth, there's clearly, deformity that's taking place, or a limb length difference. Particularly in the peripherals, we've seen this peripherally. If we have documented deformity, then we treat that as a bony bar. What I can't predict is which ones are going to release and allow you to continue growing. I think if we see progressive deformity, then that's an indication to move ahead with it. But I don't know.
Clinical.
Yeah, but I don't know how to predict if that's going to happen. We certainly have seen that release and continued growth, but it's more probably by coincidence than plan.
So one question is, what is your post-op protocol, especially for the lower limb? Do you protect weight bearing, or how do you go about it?
Yeah, I think that's a great question that I should probably include. But yes, I keep them protected weight bearing for about 6 weeks, depending on how big the cortical window is, particularly in the distal femur. Proximal, or in the tibia, probably go about 4 weeks. I'll put them in a boot and have them, modify activities and weight bearing probably for about 4 weeks, and then begin strengthening and progressive weight bearing in the boot, transitioning out of the boot at 6 weeks to walking and more of an aggressive therapy program at that point.
So one question is, at what time or time period post-op do you expect to see some growth? And a corollary, at what time post-op, if you are not seeing a growth, will you say that this has not worked and you should do something else?
I'll start with the second one first. I think it's 6 months. If you're not seeing growth at 6 months, you have to assume it's not going to happen. But I think it's going to take at least 3 months before you see anything meaningful, because you have to assume, just like every patient, when they go through a surgery or any big physiologic hit, the body's going to stop growing for about 6 weeks. So I always think that it's at least 6 or 8 weeks after surgery before they're going to actually start to grow. And then if we're talking about the distal tibia, where it's only, 3 or 4 millimeters a year, so it's going to take you 6 months to see anything meaningful. And it may take you a year before you're really convinced something's happening or not happening. But regular follow-up in that 6 to 12 month process is important. Not sure. Did I just?
Yeah.
You still?
So,
I just lost you. That's why.
Last questions. Is there any tips and tricks for other location Physeal bar, something like lower end radius, which sometimes is quite common because people try to pin lower end radius quite often, and they develop distal radius Physeal bars. So is there any tips and tricks for dealing with upper limb Physeal bars?
No, not. I don't have anything specific for that. Fortunately, we don't see a lot of the upper extremity. At least I don't, because I have upper extremity partners that take care of those, but it's still not nearly as common as you can imagine, as we see in the distal femur and the tibia. Fortunately, those physes are a little more resilient.
Yeah.
But we follow the same principles for the distal radius as far as identifying the physis, coring it out, replacing it. But I don't think it's nearly as hardy or resilient after a growth arrest as we see in the distal femur and proximal tibia.
I think one of the last questions is something preoperative. That is, so what is the instruction which you give to your radiologist? Do you do an MRI or what sequence, or do you do a CT and what sequence? So is there anything specific that you ask your radiologist?
We have a protocol. So I use a CT scan because I'm using a CT scan intraoperatively, and then I can match those images. What we get on an MRI is going to look very different than our intraoperative CT scan. We ask for thin cuts. We specifically say we're looking for a Physeal bar, so they will do 1 millimeter cuts in a very limited area. They can still do it very low dose and do it very quickly, so it's minimal exposure to the patient. But we specify very thin cuts through that area so we can really identify the location and the size.
Great. I think we are almost done with the questions. Dhiren sir.
Yes, thank you, Mandar and David, for a wonderful interaction. Now I hand over to Sandeep for vote of thanks and the further announcement. Over to you, Sandeep. Thank you.
Thank you, Dhiren bhai. So it's been really fascinating and mesmerizing, at least to say. Thank you so much, David and Karl, for your wonderful talks and cases and sparing the time for POSI. And we look forward to a continued collaboration with more such webinars on highly specific technique-related topics. And as you said, we can also have an institutional collaboration. Dhiren bhai, I guess we should look into that aspect also. Thank you very much. And I learned a lot. And I guess it's going to help a lot of pediatric orthopedic surgeons, because we do see a lot of physeal bars, and it would offer clarity on how to tackle them. Before I sign off, let me just remind everybody who's watching that on 23rd October, we are going to have the first joint POSI webinar on fracture neck femur and fracture shaft femur. And we have 3 speakers from POSNA and 3 from India. The PDF, if I can share with you in a moment, I will just try to locate it. It's been sent. Sorry, I don't have it right now, but it's been sent via WhatsApp and email, and you will be receiving reminders. There is a small registration form with it so that we just have data of the people who are attending. It will be like we conduct our webinars where we have about 10-15 people online on site like we are now, and the rest of it will be through the YouTube channel live streaming, and you can ask your questions via email or WhatsApp. So please join us on 23rd for the first ever POSI-POSNA webinar on fracture shaft and fracture neck femur. With those final comments, good night, gentlemen, and stay safe.
Thank you so much.
Thank you again. Really appreciate the opportunity.
Thank you.
Yes, thank you, everyone.